Let's start from basic anatomy of the pelvic region. The first what we need to find is a iliac crest or iliac bone, and it's really easy to find in just by palpation and placing the curvilineal transducer in the short axis plane. You'll see the bone in a continuity and the gluteus maximus muscle on top of it. Then we'll make a scan, slow scan caudally, and almost momentarily the iliac bone disappeared, and now we are looking into the gap, which is essentially the greater sciatic foramen. We'll continue scanning the bone protuberance that is technically and essentially is the ischium. And we'll continue it as long the bone looks a dome shape. That will continue scanning this dome-shaped structure until it will turn to be a flat surface, which basically tells us that we arrive to the ischial spine. When we arrive at the ischial spine, we'll center it in the middle, and now be careful, because on the ischial spine, sciatic nerve we can see the sciatic nerve in its short axis, and it's really like on a plate. So be careful with any procedures here, because you don't want to go through sciatic nerve. So if we continue scanning in the gluteal fold direction, kind of medially, we'll come to the end of the ischial spine, and here in a live person we'll see pulsation of the pudendal artery. And also in the live person we'll see a tough hyperechoic structure will be a sacrospinous ligament. The pudendal nerve is usually just medially to the artery. And if you don't see the nerve, it's fine enough, because you will always see the artery. So the procedures really literally need to be done next to the artery, avoiding artery. It's also important on a live person to avoid inferior gluteal artery that's sometimes on the way, and inferior gluteal nerve that's also sometimes on the way, just under the surface of the gluteus maximus muscle. So be very careful and concentrate on the pudendal artery. Now, there's another option to do this procedure, is to continue more distally, and now you'll see the hypoechoic structure kind of hugging the ischial bone in ischial ramus, and this is a muscle. This is the most intriguing muscle in the human body. It's an internal obliquous muscle, because it makes an acute angle, and in between the muscle. Chris, please show with in between the two muscles. So one is the obliquus, the interior obliquous muscle, and more medially the levator ana. There's a gap, and this gap is essentially the Alcock's canal. So if anyone would like to do the stimulation in the Alcock's canal, which will be more distal stimulation, it's also possible. But the more convenient and more standard approach is at the level of the ischial spine. So now we'll focus this on ischial spine. Again, we'll find this plateau and kind of slight elevation, and we'll focus our probe in the middle of this structure, leaving sciatic nerve even away, kind of away outside of the ultrasound picture. The placement is done in plane, and we'll start placing, as I said, you need to be very careful not to puncture the nerve, and it will go very carefully close to the surface and just penetrating enough to be in a space medially to the ischial spine. Now, usually, as I said, this tip of the introducer will be medially to the pulsatile artery of the pudendal artery, and nerve can be found there.
Potential areas of discomfort or muscle contractions that you see with this procedure?
So if the transducer and eventually the lead is placed on literally this place between the artery and the nerve, or next to the nerve, there are no really muscles there, so you cannot stimulate anything but pudendal nerve. if the inferior gluteal nerve is close, you may get the motor stimulation of the inferior gluteal nerve, but it will be probably rare, and you can differentiate between motor stimulation and sensory stimulation. The most important is to, as I said, to avoid sciatic nerve, will be more laterally, and to avoid any vascular damage of the pudendal artery and inferior gluteal artery.
And is this similar to any other particular procedure? Would you approach a pudendal nerve block?
It will be pretty much the same procedure as pudendal nerve block. The pudendal nerve block sometimes it's more convenient to go medially to laterally to avoid the interference with the sciatic nerve whatsoever. But for the stimulation, because we need to now to fix it on the skin and get laterally, from the convenience perspective on the patient's usability, so to speak, it will make more sense to approach it laterally to medially.